Okay, I think we'll start this webinar. Dear colleagues, good morning. Let me make sure. Dear colleagues, good morning or good afternoon, depending on your time zone. I would like to take this opportunity to warmly welcome you all to this webinar. My name is George C. Williams, and I serve as the lead for Public Health Intelligence and Risk Assessment in the Emergency Preparedness and Response Program at WHO Regional Office for Africa. I'm honored to be your moderator for today's section. This webinar is part of our Public Health Intelligence webinar series for the African region. The objective is to share knowledge and experience with the aim of building capacities and strengthening a regional community of practice in public health intelligence. Today, we are pleased to be joined by 3 risk assessment experts who will share valuable insights on risk assessment with a special focus on Mpox. Before I introduce our speakers, I would like to remind you of a few housekeeping rules. Please introduce yourself by sharing your name, designation, and organization in the chat. The presentations will be delivered in English, but interpretation services are available in both French and English. Feel free to use the translation buttons for your preferred language. If you would like to ask a question, please use the raise hand feature on Zoom for recognition. When giving the floor, kindly keep your questions brief and to the point. Alternatively, you can use the Q&A chat to submit your questions, and a colleague will be monitoring the chat to read them out. To kick off today's webinar, I would like to introduce Dr. Godwin Akpan, Lead for Information Systems and Data Analytics, who will be delivering the introductory remarks on behalf of Dr. Etienne Kwa, Program Area Manager for Health Emergency Information and Risk Assessment at the WHO Regional Office for Africa. Dr. Akpan, the floor is yours.
All right, thank you very much, George. This is very exciting times. I'll get straight to the point. On behalf of Dr. Etienne Kwa, our Program Area Manager for Health Information and Risk Assessment, it is my pleasure to welcome you to today's Public Health Intelligence webinar series. This series is focused on a critical and very timely subject, assessing the risk of Mpox in the African region. As we continue to navigate the complexities of public health challenges, this session aims to deepen our understanding of Mpox and the methodologies used to assess its risks within our communities. We're very fortunate today to have with us a very distinguished panel of experts who will share their insights and expertise on this subject. This webinar is therefore a very great opportunity to explore this multifaceted approach to risk assessment, combining both qualitative and quantitative perspectives. And your active participation and engagement will be crucial in shaping our collective response to Mpox and ensuring that we are better prepared to mitigate its impacts in the African region. So thank you very much for joining us today, and we really look forward to a productive and an insightful session. Thank you. Back to you, George.
Thank you very much, Dr. Godwin Akpan. So colleagues, just to remind you, please introduce yourself by posting in the chat your name, destination, and the organization you represent. I will now invite Dr. Samuel Boland, who is the incident manager for the Regional Incident Management Support Team for Mpox at the WHO Regional Office for Africa. Dr. Boland, over to you.
Thank you so much for the floor, and good morning, good afternoon. Thank you all for joining us today for this really critical webinar. It's great to have you on the line. As George said, my name is Sam. I am the WHO Regional Office for Africa Incident Manager for the Mpox response. As you know, this session is convened amidst ongoing outbreaks with the context of the public health emergency of international concern, which really highlights the importance of strengthening our capacities across the African region to assess, prepare for, and also mitigate the risks posed by the importation of Mpox. And conducting these thorough risk assessments is essential for guiding our public health interventions. So by evaluating key contextual factors, we can synthesize critical information and understand not only the current risk levels, but also make evidence-based recommendations and take targeted public health actions to control outbreaks. So today's session will focus on how we assess that risk of Mpox importation, whether we consider qualitative or quantitative measures. The aim remains the same: to better prepare ourselves for potential spread, identify critical gaps in our response and preparedness efforts, and ensure that we have the capacity to act swiftly and decisively. For many of us here on the call today, the focus may be primarily on preparedness. I would argue, however, that even countries actively responding to Mpox outbreaks within their own borders need to continuously assess their risk for further importation or additional outbreaks. No country is immune from the threat of Mpox, and risk assessments allow us to stay one step ahead of the virus, anticipate its next move, and prevent it from overwhelming our systems. So I want to thank each and every one of you for your continued commitment to safeguarding the health and well-being of populations during this challenging time. Your work is invaluable, and I'm confident that today's session will provide us with the insights and strategies needed to strengthen our collective response. With that, I'll hand it back over to the chair, and I look forward to today's important discussions. Thank you.
Thank you very much, Dr. Boland. Before I introduce our first speaker, is there any concern from anyone? Because I don't see from my side any introduction in the chat. Can you hear us?
I'm hearing actually from my colleagues at the Public Health Agency that the chat is disabled for them.
Oh, the chat is disabled. Colleague, can you please work on that?
Okay,
Please,
we will look into this.
Okay. Okay, so while they are looking into it, I think we will proceed. So it is my pleasure to introduce our first speaker today, Dr. Emily Perron. Dr. Perron is based at WHO headquarters in Geneva within the Surveillance Systems Department, where she leads the risk analysis for member state project. She is a former fellow of the European Program for Intervention Epidemiology Training and has served on the Detection, Verification, and Risk Assessment team at WHO headquarters in Geneva. Dr. Perron will begin our webinar with an overview of risk assessments. Ladies and gentlemen, please join me in welcoming Dr. Emily Perron. Dr. Perron, the floor is yours.
Thank you very much, George, and thank you very much for this invitation. And Samuel, you cannot imagine how I'm delighted to hear what you were saying. You literally took all the words from my mouth, and you really understood why and how risk assessment is important, especially when we want to be in advance of the virus. So thank you very much. So without any further ado, I'm gonna just to make sure that, can you see my screen? Is it? Can I confirm?
Yes, I
you
can
see my
see
screen?
from my
Okay,
side.
and in presentation mode. Okay, excellent, excellent. So my name is Émilie Perron. I'm from the Surveillance Systems Department in Geneva, and indeed I lead the risk analysis project for member states. And today I'm going to give an overview, a very high-level presentation on introduction to risk assessment. So the first question that we have to answer when we want to answer the question of what is risk assessment, the first question is, but what is risk? What do we mean by risk? So in scientific and technical literature, there are many different views on how to define risk. And I have put here only three definitions on this slide, but there are many other frameworks and models to define the concept of risk, which is a very complex concept. In the WHO guidelines on rapid risk assessment, the risk is defined as highlighted on the slide. It's the interaction of hazard, exposure, and context. And context is subdivided into two different categories, which is capacities and vulnerabilities. We will use this presentation in the rest of the presentation, and we will be focusing on acute public health event. The next question, after defining the concept of risk, is what is risk analysis? This is often an expression that we hear. What do we mean by risk analysis? So risk analysis is the combination of risk assessment, risk communication, and risk management activities. The definition of risk assessment, according to the WHO guidelines, is the systematic process of gathering, assessing, and documenting information to assign a risk level. We will enter into a bit more details in the next slide, and we will also have a great example from our colleagues in Canada. Risk communication, on the other hand, encompasses all the activities related to exchange of information, either to authorities, to partners, and to communities, affected communities, for them to implement the countermeasure that we recommend and to build trust. And then the last aspect of risk analysis is risk management, and risk management is the process of implementing the right interventions following a risk assessment. But what is risk assessment in practical life? So according to the WHO 2012 guidelines, risk assessment is the combination of hazard, exposure, and context. And after the collection of information, we will have to assign a risk level. The information provided can be data or can be informative information, qualitative information. So any kind of information and data that can give us attributes to the hazard, exposure, and context that is defined as capabilities and vulnerabilities are useful to triangulate this information for us to transform those information into a risk level, into recommendations that are practical and implemented at country level, and also to give us the level of confidence. Because one thing that we absolutely need to do when we perform a risk assessment is to give the level of confidence of the information provided in this risk assessment. I remember that I was part of the very first risk assessment that was performed for COVID. At the beginning of the pandemic, we even did not know that it was COVID. We had plenty of gaps in the information provided. So it's very important, as soon as we give a risk level, is also to give the fact that we are missing information and to have all those information missing listed. Risk assessment is an iterative process and should be repeated when new information is available or when the situation is evolving. You can set up predefined criteria to start a risk assessment and to redo a risk assessment, but the process should be also flexible, and it should be up to the risk assessors as well as the supervisors to decide whether to start and whether to redo, to update a risk assessment. As mentioned by Samuel, the methods to assign a risk level can be quantitative, qualitative, or semi-quantitative. And we will have a great example of Canada. But again, what I want to emphasize is any kind of data, models, parameters, scales that can give you any insight on those three dimensions should be used to triangulate the different information. So we're here in a webinar related to public health intelligence activities. So I wanted to put back right in the center, the risk assessment process, the risk assessment step within the public health intelligence activities. So as soon as we have detected something, something that is abnormal, we need to verify this information. So the question that we have to answer is this information the truth? Or is it something that is a rumor? And this I can discard this information. But as soon as it's verified, then you have to perform a risk assessment to assign the risk level, to identify the good recommendations and interventions, and also to identify your information gap. We have at WHO two kinds of risk assessment that we recommend for member states. The first one is an initial risk assessment that is very quick, very easy to do, and another one that is a rapid risk assessment, more thorough, more in-depth, and during which you need to reach a consensus with experts. And then the last step is the communication and all the actions that needs to happen either in your organization, but also outside of your organization. And then this is a cycle. If you have an additional information, you detect additional information, then you have to verify, then you reassess the risk, and then you communicate again. At WHO, we have two main guidelines related to risk assessment. The first one is from 2012. This is the blue guideline on the left-hand side, and for rapid risk assessment of acute public health event, and the other one, which is the strategic toolkit for assessing the risk. Those two guidelines are very, very different. The term risk assessment is used in the titles of both guidelines, but actually the output are very, very different. So because I know that in the African region, you are performing a lot, you are using a lot the STAR, I just wanted to make sure that the difference is well understood. So let's start with the objectives. When you perform a rapid risk assessment, the objective is to assess the potential of an acute event to negatively impact the human health, to recommend specific action, and to guide the communication strategy. In contrary, when you use the STAR guidelines, it's to assess the risk of health emergency and disasters that may impact negatively the human health. And the may is actually very important because the event has not yet occurred in your geographical territory, administrative territory. And the second objective of the STAR is to support health emergencies and disaster risk management and to plan activities, to plan future activities. So really, when you are performing a rapid risk assessment, you're in response mode. Something wrong has happened in your country, you assess the risk, you implement the countermeasures. When you do a STAR, you look for very long time, 1 to 5 years activities. So when you do a rapid risk assessment, it's immediately after a public health event has been detected. When you do a STAR, it's primarily conducted during preparedness mode. You have the time. You know you think that you know what will going on. You're in preparedness time. There are also two different methods in the rapid risk assessment. Hazard, exposure, and context are used. And for the STAR is probability and impact of potential events that are used. The participants are also slightly different. When you perform a rapid risk assessment, you want to have around the table experts in the pathogens or in the event. And for the STAR, you have much broader colleagues and participants during the STAR workshop. You have different levels of the government, different ministries and public health institutions, intergovernmental organizations, as well as sometimes the private sector. In terms of time frame, as I mentioned, rapid risk assessment is rapid and ideally should be performed in less than 24 hours. This is sometimes not realistic, so no pressure at all. This is a recommendation, less than 24 hours. But if you need 48 hours, this is also okay. And for the STAR, usually it's more than 1 week, and it's during a workshop that is organized and planned in advance. In terms of output, unfortunately, in the rapid risk assessment guidelines, there is no predefined output for the member states. But for the STAR, this is very well defined. At the end of the workshop, you get a country emergency risk matrix table, which is very well defined. And this is my last slide. You've understood that rapid risk assessment is a complex and iterative process. You will have a concrete example right after, so I will not enter into much detail in terms of the methods. You have understood that WHO has issued a guidelines on rapid risk assessment, but this guidelines is not yet very well operationalized. So we have started a project on risk analysis for member states, and the objective is to enhance the member state capacity to perform their own risk assessment during a public health events. So on the contrary of STAR, this is complementary, but this is not the same. This is not the same process. And the key project output is a harmonized and standardized toolkit to support member states. The toolkit can be used to assess the risk, to recommend measures based on evidence, to support resources prioritization, as well as to provide basis for risk communication. Voilà, that's it for me, George. Over to you.
Thank you very much, Dr. Emily Perron, for this very insightful presentations. I will now go to the audience for any questions or comment. So please raise your hands and you will be recognized, or you are free to post your comments in your questions in the chat and we will read them out. Is there any question in the chat? Is there anyone who has a question or comment? Please raise your hand. I cannot see any hand. Mauricia, is there any question in the chat? Okay, we have Sally. Sally Ann, over to you.
Okay, can you hear me?
We can hear you,
Yes.
but please be a bit audible.
Okay, I hope it's better. Thank you. Yeah, so thanks very much for the presentation. So I wanted to find out who does the risk assessment, like after an outbreak. A lot of the times it appears is the WHO team in the country office, or is it supposed to be the ministry, or it's a combination of both? Thanks. Over.
Thank
George,
you.
do you want to answer, or you take a list of questions?
Just take note. We'll take a few questions and then you respond to them. Freddie Kambale. Freddie, you are muted, please.
Oh, yes, thank you. So the question was around the risk assessment for member states, these projects. So I know it's different from the risk assessment we are talking about. So I think that this project will also enhance member state capacity in performing rapid risk assessment, which is part of the wider risk assessment. So if it's the case, can you please confirm and maybe tell the plan for future, if it will be extended to all member states? Thank you.
Okay. Amy Takahashi.
Hi, good morning, afternoon. My question was whether there was a standardized assessment template for Mpox specifically that might be looking more at the readiness, so a bit more agile than the preparedness star, but for settings where there hasn't been a confirmed outbreak just yet. So it's something in the middle between, I guess, the rapid risk assessment and the star, and whether there is like a template for Mpox specifically that is standardized. Thank you.
Thank you, Emmy. So, Dr. Perron, do you want to respond to this first round of questions?
Yes, absolutely. So, Sally-Ann, who does the rapid risk assessment in member states after the detection of an outbreak? Each country is sovereign. My suggestion is to do it in collaboration with WHO. WHO country offices colleagues are always involved in the development of tools. So,
Dr. Perron, you sound a bit low. Seems like you are a bit far from the mic. Can you get closer? Probably it's from my side, but
is it better like that? Sorry, now I'm just.
Yeah.
Okay, thanks. Sorry. So my answer was each country is sovereign. And this is really up to the country to decide who is responsible to perform rapid risk assessment. Though, however, my strong recommendation is to do it in collaboration with WHO country offices colleagues, because they are well aware and trained to perform risk assessment. So my strong recommendations is to do it in collaboration with WHO country office. The second question was whether this project will enhance the capacity of member states to perform their risk assessment. Absolutely. This is the aim of the project, is to enhance your capacity to perform your own risk assessment in collaboration with WHO country offices colleagues. And will it be expanded to all member states? Yes, it will. So just for your information, very quickly to explain you the project and the different phases, we interviewed countries, 19 countries all over the world to understand the needs, the different needs. And we had a meeting with the countries to address to prioritize the different needs. And one of the first need was, please, WHO, develop tools for us to do rapid risk assessment. We developed 2 tools and we piloted them over the summer. We are now in the process of finalizing the pilot, the analysis of the pilot phase, and we aim to have those documents, those tools, as well as the user manual published at the beginning of 2025 to all member states. In terms of the third question, do we have standardized risk assessment templates for Mpox specifically and for readiness activities? This is slightly outside of my mandate, outside of the mandate of the risk analysis project. So I don't know if, George, you have anything to share related to standardized risk assessment. It's not risk assessment, actually, standardized template to assess the readiness of countries for monkeypox. Maybe we can follow up offline for these questions to identify the right team at WHO who will be able to answer.
Yes, there is a tool. There is a tool for assessing readiness for Mpox. And there is a team here at WHO that has been working on this with countries in the region. So we can share with you the resource that is available for assessing readiness for Mpox, but there's a tool that exists.
Okay,
yeah.
Excellent.
Okay, I will just take another.
George, you're muted.
Okay, sorry, I'll take another round quickly. David Prito, please go ahead.
David, unmute, please.
David, can you hear us? Please go ahead. You can unmute and pose your question. while we are waiting for David, Emily, there's one question in the chat. How different is this Mpox risk assessment from other assessments like cholera?
Excellent question. So the idea in the risk analysis project, the idea is to develop tools that are disease agnostic and flexible enough to be used to any kind of biological hazard. My dream would be to have one tool that is agnostic of hazard and can be used in any kind of settings. It appears that it's a bit challenging, but at least to cover any biological hazard is the objective in the risk analysis package for member states. However, our colleagues from Public Health Agency of Canada developed a tool specifically to assess the risk of importation for Mpox, and you will understand later why, because there is a model behind, and each model is really disease specific, because each disease has specific parameters and way of traveling, and the transmission pattern are different. So the tool that we developed for inside the risk analysis package are disease agnostic, but the example that you will see here is monkeypox specific.
Thank you very much, Dr. Emily Perron, for this very insightful presentation. Our colleagues, we may not be able to address every question or comment due to time constraints. We will consolidate all of them and share the responses with you afterward. So you are free to pose your questions in the chat. We will collect them, we'll consolidate the responses and share them with you. Also, the recording of this webinar will be shared along with the presentations with you. So you are going to get all of this material. So without much ado, we'll now move to our next speaker, Dr. Lisa Canary. Dr. Lisa Canary holds a doctorate in applied mathematics with a specialization in biomathematics. In 2017, she joined Yukon University as a professor of statistics, where she contributed to the NSERC Emerging Infectious Disease Modeling Initiative, which is actually a network of specialists across Canada focused on using models to address public health challenges related to infectious diseases. Since 2023, Dr. Canary has been an infectious disease modeler with the Public Health Agency of Canada, focusing on disease dynamics, including importation, modeling, and scenario analysis for respiratory infections in Canada. Ladies and gentlemen, please join me in welcoming Dr. Lisa Canary. Dr. Canary, over to you.
Thank you so much for the invitation to speak today. I will be presenting an overview of the disease importation model, for which results contributed to Dr. Fiona's rapid risk assessment. My team, Emily and Rania, are here today as well. Oh, hold on. The objective of the model is to calculate the risk of introduction of infectious diseases into Canada via air travel. The model inputs that we provide are Canada Border Services Agency data to inform travel volume for each source country into Canada by Canadian and foreign traveler groups. We also have access to the International Air Transport Association data to inform passenger numbers and route information. We also have the populations for the source countries by year. And using the National Travel Survey, we also have the information of distributions of Canadians' time spent in source countries prior to returning to Canada. Okay, there is also a list of model inputs that we require to be provided to us about the affected countries that we model. We will need the time period to model, the list of countries with the source of infection. We will call these the source countries from here on in. We need to know the number of newly reported cases by source country during the time period, the correlation factor distribution for case counts. So this accounts for underreporting and asymptomatic cases, susceptible population proportions by country, and the disease latent and infectious period distributions. We will provide the math model and the methodology with the deliverables, and we also provide guidance towards calculating some of the necessary epidemiological information. So the model outputs that we provide are estimates on the number of disease importations into Canada and the probability of disease introduction during a specific time period. We can provide these results by Canada as a whole or by specific airport. The next set of slides that you'll see is an example, as Dr. Emily mentioned, that this is the recent Mpox modeling exercise that we did. Okay, so the model that we did run was for September to November and for the Democratic Republic of Congo and Congo. So those would be our source countries. Although there are only 0 mean cases expected to have entered into Canada during this time period modeled, we thought it would be important to show you that a risk map of all the source countries is provided. Okay. We also provide a set of summary statistics tables by traveler group and country, which include the number of travelers, the minimum, maximum, mean, median, and percentiles, and also the probability of at least one imported case. And we can add another probability of as well. In this case, we did the probability of at least 2 imported cases. You'll note that these values are separated by country and traveler group in the first column. And it also should be noted that the privacy of the travelers is maintained when arriving into Canada, as values of 10 or less travelers are suppressed. Okay. The model also produces probabilities of importing cases from the source countries into Canada for all travelers in this case, and by traveler group here. Note that the scales for the X and Y axis are the same, but this can be changed to reflect the probabilities and case counts per traveler group. Okay. Then we also have the probabilities graph by source country. So these are discussions that we will have with the group requesting the modeling be done, and we can adjust the graphs and information as necessary. We also provide the CSV of all the data that the model produces so that people can make their own analyses and conclusions. Okay, we also provide, oh, sorry, just give me 1 second here. The probabilities of not importing a case into Canada, in this case for all travelers, by traveler group, and by country. So this is the probability of not importing. These slides are grayed out a little bit because I just wanted to indicate that we do provide a set of assumptions so that we can acknowledge the limits of the model. And we also provide a list of data sources that we used to run the model. So this was a pretty brief overview as I'm part of Dr. Fiona's presentation, which I'm going to help her with the next set of slides as well. But just as a summary, the disease importation model provides risk maps of imported cases expected to have entered into Canada, summary statistics, probability of disease introduction into Canada by traveler group and source country, as well as assumptions and data source lists. I also wanted to acknowledge that that the following people are developers and users of the model. And that's it. I'm going to just hand it over to Fiona. And I'm going to switch the slides for her for the next set of slides.
Okay, thank you, Dr. Lisa. Before we get to Fiona, we will open the floor for questions. I think this is very important, and it's good to see your approach to assessing the risks of importation of Mpox in Canada. As we know, in our region, we have around 13 countries that have reported cases of Mpox. Not all of the countries, not all of the member states in the region have Mpox cases, but one of the questions that keep coming up is, what is the risk of importation in places that are not affected? So this presentation is very important. You using a mathematical approach to assess that risk of importation, and I guess many people are interested in having a little more in-depth understanding of this approach and the limitations as well. So I will open the floor for questions and comments. Please raise your hands if you have question or comment on this presentation. Over to you, colleagues. Dr. Okeri, Ifeoma Okeri. Ifeoma Okeri, please go ahead, unmute, and pose your question. Can you hear us, Dr. Okeri? Okay, Dr. Tieble?
Hello, yes. Thanks, Dr. George. Thank you very much. Can you hear me, please?
Yes, I can hear you. Please go ahead.
Okay, thank you, Elisa, for the great presentation. And yes, it's good to model, but because lack of data will be one of the challenge. Then the next is, I haven't seen the test sensitivity and specificity and even the prevalence about this. So I'm wondering how you're going to quantify the risk here. So that's one of the issue I was looking for, because we developed a tool called joint risk assessment due to the lack of data. And that's a quantitative operational tool we use. It is available online, and we have used it for Mpox as well, even in DRC. So thanks. Over to you. If you can talk a little bit about the performance of tests you're going to select to do this modeling. Thank you.
Thank you, Dr. Tiable. Ifeoma, so Dr. Canary, please take note. We will take a few questions and then you can respond to them. Ifeoma, I see your hand up. Can you go ahead? Are you able to unmute yourself? If not, probably you could pose the question in the chat. Okay, we can get Ifeoma. So we will, I don't see. Okay, there's a question from Christopher. Which type of model did you use for these estimates? Which type of models did you use for this estimate? Then Leona, thank you, Dr. Lisa, for the presentation. Please, can we have access to the CSV database you just referred to? It's a request. Dr. Sally Ann, over to you.
Yes, thank you very much. And thanks very much for the interesting presentation. Based on the results of the modeling, what action is taken? I'm assuming that this is done to inform some action. So could you maybe elaborate on how it can be used for action. Thank you.
Thank you very much. And I will take one more from Caleb. Thank you. It's unfortunate I could not clearly get the assumptions highlighted to present some weaknesses in the disease modeling. Can these be given? So he's talking about the limitations or the weaknesses of your model. So over to you, Dr. Lisa.
Okay, I will try to answer every one of these questions. Okay, so as far as sensitivity analysis, we don't have confidence intervals at this point. We can actually share our methods and information, the model information at a later date. And I have a document ready for anybody who's interested. And then the other question was what type of model? It's basically a statistical model. And I think underneath everything, it's basically a binomial distribution that we're looking at. But we have to do a bunch of different things so that we can get probabilities for at least X number of cases entering into the country with X number of source countries. So we do a little bit of like randomly selecting based on distributions. And access to the Mpox CSV data set, I think I can give you access to that if you'd like to contact me directly. I think we can discuss that. And what action is to be taken based on the importation modeling results, I think I'll leave that to Dr. Fiona, who's going to speak to that next. I think she'll be going into more detail about what happens with that, because our results actually fed into her rapid risk assessment. And then the assumptions that are highlighted, I can actually probably copy and paste those into the chat if you want more information about that. I hope that that answers all of your questions.
Okay, thank you very much. Are you able to measure a few of the assumptions?
Measure oh, yes, I can. Hold on here.
Mention a few.
Yes, I can. Hold on here. Just let me look through. I've looked through this in a little while. Reported cases. Okay, so the reported cases from each source country are assumed to be uniformly distributed throughout the months of the modeled period. Number of new cases is assumed to be negligible compared to the country population. So basically, we're just looking at the whole time period, and we're not keeping in mind that new cases are coming in during the modeled period, or that's changing the susceptibility. Travel volume throughout the modeled time period is assumed to be negligible. So again, we're not looking at if people are leaving, that it's making an impact on the population. Infected Canadian travelers are assumed to have negligible impact on the rate of infections in the source country. So we're just looking at small numbers of people traveling compared to the populations. Each of the total latent and infectious periods are assumed to be the rate of infection is the same. So basically, when we're looking at the latent and infectious periods, during the time span that's modeled, we're assuming that it's the same before the time modeled. Importation estimates do not account for infections during travel. So we're not looking at people that are getting infected during their travel. And then the travel categories are just based on our CBSA data that comes to us as Canadian and foreign traveler. The model is based on air travel only. We don't have land and marine, although I do think that in the past we have modeled land travel. We're looking at a correction factor. Okay, that's just specific, I think, to Mpox, that was a little bit on the higher side. And that information came to us. The model assumes that the country population is representative of the traveler population. So we're looking at that the population that is traveling represents the same vaccine and infection rates that are in that country. Travelers departing from the countries with large wealth and income inequality. So we're looking at the fact that maybe that people that are traveling may not exactly represent the entire population as a whole. And that's the same for the age and gender distributions as well. Individuals with severe clinical signs may opt to cancel their travel or not be allowed on board, which could lead to an overestimation of importation risk. So that's the same again. We're assuming that the population in the country of departure is representing what the people that are traveling. So there is a chance, though, that people who do get sick may opt to not travel, but they can't opt to not be part of the population. Our model results do not distinguish between Mpox clade 1A and 1B, and then we have our assumptions and how we calculated the susceptibility proportions that are included, as well as, like I mentioned, the document that explains the model. So I do have a document ready to share with anybody who's interested, but I do think that it probably will take a lot more time than we have available here today to go through that in depth. I hope that answered your questions.
Thank you very much. Thank you so much, Dr. Lisa, for this. Definitely, we knew that this would take a lot of time to go in depth into this model. But it was so insightful that you are able to share a very high level highlight of this process. And there are several resource materials you have. We appreciate if you can share this with us. I think there are some links that you can just drop in the text, but we'll also be able to package and share with all of those who have joined this call. So thank you so much for this presentation. So we will move now to our final speaker on this series. Our final speaker is Dr. Fiona Guerra. Dr. Fiona Guerra holds a PhD in microbiology and immunology, along with a master's in public health. She has extensive expertise in communicable disease epidemiology with a particular focus on vaccine-preventable diseases, emergency response, and risk assessment. She has worked in public health at the provincial level in Canada and has also gained international experience in Bangladesh and South Africa. She currently serves as a senior risk assessor with the Public Health Agency of Canada. Distinguished ladies and gentlemen, please join me in welcoming Dr. Fiona Guerra, who will present to us on the qualitative aspect of risk assessment for Mpox in Canada. Dr. Guerra, over to you.
Thank you. And thank you for inviting the Public Health Agency of Canada to share our approach for rapid risk assessment for the current clade 1A and 1B Mpox outbreaks. As Lisa mentioned, she's kindly offered to help me with my slides. So next slide, Lisa. Thank you. So in my presentation today, I will first provide a very, I would say crude, maybe high level overview of what our rapid risk assessment method and process is. And then I'll focus in on our method and our results for the estimation of importation likelihood of Mpox into Canada, and then end with a summary of what some of the strengths and challenges were with this process for us. Next slide. So we use RRA as a short for rapid risk assessment. So the Public Health Agency's method is adapted from the WHO, FAO, WOAH Joint Risk Assessment Operational Tool, or you might know it as the JRAOT, with some additional components from the ECDC's Rapid Risk Assessment Operational Tool, as well as the WHO RRA framework. And so in short, our process usually starts with a risk framing. So that's going through a series of questions where we are essentially scoping out the risk question. We will also devise a risk pathway. So on the slide that's shown on the left, it can be a helpful visual aid, I think not just for the users at the end, but as we're going through the process of the risk assessment. And so in general, that would start out with your infectious agent. If it's a vector-borne disease, you would start out actually maybe with the vector, or if you're thinking about a specific outbreak, then we would move down to what is the likelihood of human exposure, then the likelihood of infection or human susceptibility, and then we would consider different human-to-human spread scenarios, or the most likely spread scenario, and then look at the individual level and population level impacts of that spread scenario. So that was, in general, sometimes steps will be combined. It depends on the context. And so with our risk framing and our risk pathway, we then create an overall risk question. And that encompasses, that's shown in the different colored words. So the what, the where, the when, and the how. And I've described this in a sort of linear fashion, but in reality, it is, I'd say, not so linear. It's quite iterative. We kind of work between those three pieces: the risk framing, the risk pathway, and the risk question. And then we need to gather the information in order to come up with our estimates of likelihood and impact. And we have scales, which are shown in the two tables in green. So we have scales for the likelihood and scales for the impact, as well as a scale for uncertainty that we will assign to those estimates of likelihood and impact. And throughout this process, we have a technical team as well as a steering committee. And so these are groups of experts and stakeholders that come together and help us when it comes to, at the start, the framing of the risk question, as well as in identifying the evidence that we're going to use, and as well as in reviewing the estimates that we come up with for likelihood and impact. So again, that was a very quick overview of our method. But next slide. So that was, those were essentially the steps that we took when we were doing our recently published rapid risk assessment on clade 1A and 1B Mpox outbreaks, with a few tweaks owing to the fact that the WHO declared a public health emergency of international concern, as well as how rapidly the context was changing. So there were certainly some steps in that process that were, at the very least, expedited. And so I encourage you to please, it's not just a shameless plug, I encourage you to look at our completed risk assessment. It's on our website, because our risk assessment does look at not just importation, but a likely spread scenario within Canada, and then again, individual and population level impacts. Whereas today I'll be focusing just on the first part, the importation. Next slide. So for the current clade 1 A and B outbreaks, our risk framing and pathway led us to the following risk question, which is on the left of your screen. So what is the likelihood of clade 1A or 1B MPXV importation into Canada and the impact of onward spread in the next 3 months? So that was September to November inclusive. And so just referring back to the pathway I was describing, in this case, we started with the green rectangle, which is the multi-country outbreaks of Mpox, Mpox clade 1A and 1B. And then we looked at what is the likelihood of importation into Canada. From there, if there were importation, what is a likely spread scenario within Canada? And then at the bottom two rectangles, what would be the individual and population level impacts in Canada? And we did this, we looked at this pathway and considered both clade 1A and clade 1B separately. So we disaggregated our estimates for those two clades. Next slide. And so again, today's focus is on the importation. So our specific sub-question was, what is the likelihood of at least one traveler infected with clade 1A or 1B entering Canada in the next 3 months? So next slide, please. I'll get into our results. So we were doing our risk assessment mid-August to late August. So as of that time, we estimated a low likelihood of a traveler entering Canada with infectious clade 1A between September and November. And the rationale for the estimate, the key rationale for the estimate were as follows. So clade 1A had not yet been reported outside of any African countries. And yet that outbreak, those outbreaks had been ongoing for several months. As well, clade 1A is associated, or clade 1 had been historically associated with transmission from wildlife, followed by limited chains of human-to-human transmission that died out. And in terms of human-to-human and in terms of Canadian visitors to outbreak countries, they would be less likely probably to interact with wildlife. So in terms of the risk of exposure for Canadian travelers to outbreak settings. As well, cases of Clade 1A were more common in the EPI in children and in rural and in forested areas. And so we thought it was reasonable to assume that these would likely be less internationally mobile populations, as say compared to adults or adults in urban settings. As well, the countries that were reporting Clade 1A outbreaks have had relatively low travel volumes to Canada within the time period we were looking at, September to November. And so just referring to the model that Lisa described, when they ran the model, it indicated a 19.4% chance of an infected traveler with Clade 1A or 1B entering Canada via air travel from the DRC between September and November. So our estimate of this low likelihood of Clade 1A import was assigned a high uncertainty. And so there were a number of drivers for this uncertainty. The transmission dynamics of Clade 1A are unclear. So historically, it's been associated with zoonotic transmission, but within the current outbreaks, I think the relative contributions of zoonotic transmission, close contact transmission, and sexual transmission are unclear. And that was a consideration for us as it makes it less certain as to how likely cases would be to be exported. As well, the potential impact of outbreak control initiatives introduced some uncertainty. So we know the WHO and regional offices have proposed guidance for member states to support outbreak control efforts globally. And as of mid to late August, and perhaps even now, it is a bit uncertain what the magnitude of those efforts will be and what their effectiveness will be. As well, the travel data contained some uncertainty. So referring to the model projection of 19.4% probability, there was some uncertainty in the data that was used, which Lisa described, as well as some limitations for the use of that specific model for our importation likelihood. And I'll get a little bit more into that near the end. And I think that will help to address some of the questions that came up for Lisa. Next slide. So that was Clade 1A. For Clade 1B, we estimated a high likelihood of an infectious traveler entering Canada between September and November. And our rationale were as follows. So there had been reported cases, so one case in Sweden and one case in Thailand. So we had seen cases outside of the African countries having outbreaks and outside of the African continent. As well, there was evidence of sustained human-to-human transmission for Clade 1B, and that came from the case descriptions in the EPI reports, as well as in the scientific literature. In addition, there were cases being reported in sex workers and sex worker clients, and sexual transmission as a possible mode of transmission. And so given that, there is the potential for rapid spread if this Mpox were to enter into high contact sexual networks. As well, Clade 1B cases were being reported in urban centers, which have maybe a greater likelihood for international mobility. And as I stated for Clade 1A, and as Lisa mentioned, we combined the cases for Clade 1A and Clade 1B when coming up with the importation probability estimate. And that was, again, 19.4% chance of an infected traveler with Clade 1A or 1B entering Canada via air travel from the DRC between September and November. And for this importation likelihood, we assigned a moderate level of uncertainty. So we felt that the evidence was, we thought that the evidence was quite strong that Clade 1B will continue to appear internationally. However, there was uncertainty introduced by this uncertain impact of outbreak control efforts, as well as some uncertainty introduced by the travel data that was used, as well as some of the limitations of the model in this case. You can go to the next slide. So this slide and the next one both summarize the considerations, the data sources, and our findings that we used to inform our importation estimate. So I'm not going to go into detail on these two slides, but they will be in the presentation for your reference. And I'm not sure if the presentations are shared, but they would be available to you there. If you could skip forward 2 slides, please. I'll jump to, yeah, that's great. So at a high level, this is the logic that was used to populate those tables and to come up with our estimate for the likelihood of export of an infectious person from the outbreak countries and importation into Canada. And so the thinking was, in order for an infectious person, whether they are Canadian or non-Canadian, to enter Canada, we can first ask, what is the likelihood that someone in the outbreak country will be exposed to Mpox? And so there are a number of circles there that give some examples. So we would think, want to gather information on, well, what's the length of stay for Canadian travelers to the outbreak countries, as well as what is the prevalence of clade 1A or clade 1B? Is there a trend that we're seeing? And then once we consider, okay, what are the possible exposures, then what about the likelihood of infection within that outbreak country? And so for that, we wanted to gather information on what is the susceptibility? What is the susceptibility of Canadians to Mpox infection? And I mean immune susceptibility, and as well as within the outbreak countries. And you could ask questions like that, or even in general, you would want to know, okay, does infection or vaccination confer sterilizing immunity? So that's the kind of information, as well as what would be the effective reproduction number, to try and get a sense at how transmissible this infectious disease is. And then lastly, the question of, well, how likely is export from the outbreak country or import into Canada? And so for this, we looked at different types of information, including, we considered how mobile are the susceptible or infectious populations. So this is when we considered, individuals in urban settings as opposed to maybe children in more rural forested areas. We also would consider, are there major holidays coming up, for example, that could increase outbound travel from the outbreak setting or increase inbound travel from Canadians. If you can go to the next slide. So as you can see from the exposure, infection, and importation questions, there were a variety of types of data that can be used in our method to answer the question of the likelihood of importation, and that we considered, including travel data, serological surveys, vaccine coverage, secondary attack rates, and so on. And of course, we would always strive to use the highest quality evidence, but often there are knowledge gaps. And so in that case, we sometimes used non-peer-reviewed reports, including preprints, as well as expert opinion, which is where our technical team and our steering committee or oversight committee were involved. As well, we were doing a qualitative assessment and coming up with a qualitative estimate, but we also used quantitative data. So as Lisa just described, the probability of importation result was one of the components of our likelihood of importation when we were coming up with that likelihood. If you can go to the next slide. Oh, yeah, that's perfect, actually. So this is my second last slide, and it's just a reminder that our rapid risk assessment goes beyond importation and looks at spread within Canada and the impact on Canadians. And so I'll, in my last slide, discuss a bit about the strengths and limitations of our experience, but just keeping in mind that the rapid risk assessment looks at beyond importation into other stages. And so the strengths and limitations are a bit relevant to the overall risk assessment. So next slide, please. So this is my last slide. So I'll highlight some of the strengths and some of the challenges with this rapid risk assessment on Mpox. So I think a strength for sure was that we, integrated qualitative and quantitative data in order to generate our qualitative likelihood estimate. We also collaborated with partners from across and outside of the Public Health Agency of Canada. So we worked with folks in surveillance, in the lab, with modelers, vaccine lane, border services, immigration. And I think another strength was that we decided to provide clade-specific estimates, which was challenging and required working with rapidly emerging data. But it became clear to us that that was probably going to be the most beneficial thing, as there was clearly different outbreaks occurring, and that needed to be differentiated where possible. There are, as I said, a number of challenges or limitations that we encountered. I think for sure the limited evidence was challenging, in particular the limited evidence on current modes of transmission and the current outbreaks, in particular for clade 1A, as well as very limited evidence for us to try and inform our potential spread scenarios due to a lack of evidence on what spread or impacts look like for Mpox in non-endemic settings. So we did have, of course, clade 2B, the clade 2B outbreak as a reference, but of course there is some uncertainty about whether or not clade 1A or clade 1B would behave similarly to clade 2B. And I think probably most relevant for today was the fact that we were challenged by the validity of the quantitative evidence that we were using as the context was changing so rapidly. So the model that Lisa described does not provide a projection into the future. And so it assumes that you're looking at a consistent number of cases. So you look at, okay, there were this many cases in like this many weeks. And so that's the number of cases that you would use in your model input. And so we really had to discuss the validity of the modeled probability of importation, because one of these model inputs is the number of cases, and that was something that was changing rapidly. So in particular, in the case of Burundi, we thought, okay, the outbreak at that point, it was mid-August, and it had just taken off, but cases were really increasing quickly. And of course, another model input is the air travel volumes. So we thought of the example of Kenya, where there were just a few cases, and that could have been the start of what could have become a very big outbreak from a country that had really high travel volumes. And so that, again, may have resulted in a probability of importation that within a few weeks may not have been relevant. So the risk assessment team, in consultation with our surveillance colleagues, we made the call that we would not try to get an importation probability estimate for Burundi or for Rwanda. Again, because of the rapidly increasing cases in Burundi, and in the case of Kenya, small number of cases, but high travel volumes to Canada and globally. So we decided to err on the side of caution and focus more on the qualitative evidence that we were using to inform our importation estimate. So that really got more weight in this rapid risk assessment when we were thinking about importation. I think certainly the importation model is informative and could be really helpful, maybe internally in real time, but just given the time it takes for us to review a risk assessment and then post it within that window of time for a context that is changing so rapidly, there are definitely limitations. So if you can go to the last slide. I just want to acknowledge all of my wonderful colleagues, many of whom I think are on the call, and I invite them to chime in if there are questions. And thank you again for having us.
Thank you very much, Dr. Guerra, for this wonderful presentation. This is quite insightful to learn how you at the Canada Public Health Agency is able to produce this work to inform the risks of Mpox in Canada. So colleagues, over to you now for comments or questions. Again, you are free to post your question in the chat, or you raise your hand and you will be recognized to ask your question. Remember, this is a knowledge and experience sharing section. And the context may not be exactly the same, but there are a lot we can learn from this presentation. So please feel free to ask your question. I don't see any hand for now. All I see is a lot of thank you for this great presentation. Thanks a lot. Is it that this presentation was very clear and you are receiving a lot of thanks? But colleagues, if you have any question or comment, please do not hesitate to ask. Emaresian, do we have any question in the chat? Emaresian, are you there? Okay, I don't see any question in the chat, and I don't see anyone who has raised his or hand. So
Can I ask
guess
a quick question? Are people actually able to voice a question?
yes.
Okay, so they just need to raise their hand. Sorry, some colleagues are asking if they can ask a question.
Please feel free to raise your hand, and you'll be you'll be asked to pose your question. Okay, so I don't see any question. There's no hand up. There's no question in the chat. So I believe this presentation was quite clear and very useful for us in the African region, learning from what you are doing in Canada and see how some of these concepts can be applied to the context in the African region, particularly at the time we are responding to several outbreaks of Mpox across the African region. So before we close this this webinar, is there any final comment from you, the presenters? I will start with Emily.
Yes, thank you very much. So my final comment is in my last slide, there was a thank you, but there was also a picture. So I want to acknowledge the fact that I'm not the only one, sorry, I'm not the only one working on this risk analysis project for member states. We have Bernadette Mirembe, we have Sabina Stoitova, we have Peng from Singapore, and we also have the constant support from Public Health Agency of Canada. So I really want to thank again Public Health Agency of Canada for their critical support and their expertise and generosity in sharing this expertise. Thank you very much.
Thank you, Emily. And I think it was very good to mention that this risk assessment for member state project that you are leading. So this is just another opportunity that we are able to get back to you, member states, to build capacity. So we're going to be working with you on risk assessment. I know within WHO, we have been doing a lot around risk assessment internally. But we need to have the same level of capacity in our member states to do risk assessment, particularly in a region where we are dealing with so many outbreaks and health emergencies. It's important to have that capacities at our country level. So definitely we'll be working with you on this project. The tools are being developed. I think there's an interim version available. We hope to have the finalized version soon, and we will be working with you in our different member states to build these capacities for undertaking risk assessment for outbreaks and other emergencies in our region. So thank you so much, Emily, and all the team for the collaboration and the good work on this one. So I'll go to our colleagues from Public Health Agency of Canada. Maybe I'll start with Dr. Lisa. Any final comment?
No real final comment. I have the document ready in PDF form, so I will send it to you if that's okay, and then maybe you can distribute as necessary. Thank you again for having us, and That's it. Thank you.
Thank you. Thank you so much, Dr. Lisa. I think it's really good to see the mathematical side of things. Sometimes, a lot of colleagues are more interested in the quantitative approach to assessing the risks and how, there's this perception that the quantitative approach tend to be more objective. So, so it was good to share that with us, and we look forward to receiving all the documents we will share with all of those who have joined the call. Dr. Fiona, over to you.
Yeah, I also want to just echo the thank you for inviting us to share what our approach was. And also want to express my thanks to the WHO. We obviously rely very heavily on the resources that you create. So thank you very much. And we invite anybody who has questions. Our email is on the last slide. So please don't hesitate to reach out. Thank you.
Thank you. Thank you again, Dr. Fiona and the whole team from Public Health Agency of Canada for this great presentation. I think it's really wonderful. And again, I would say you are sharing this presentation at the right time when we are dealing with outbreaks of Mpox in our region. And this capacity is very important for across the member states in our region. So we really appreciate this collaboration. And I want to say this is Public Health Intelligence webinar series. So risk assessment is just a component of the public health intelligence landscape. So we hope to regularly engage with you on these different topics that border on public health intelligence in our region. And we look forward to seeing you again, Dr. Lisa, Dr. Fiona, Emily, and all of you who have joined us on the call in subsequent webinars or other forums where you will be able to exchange and share more insights on different aspects of public health intelligence. So colleagues, thank you so much for joining this call. Please, if you have any questions, do not hesitate to share with us. We will compile those questions and with the respective answers and share back to you. We will also make sure that you get these presentations along with the different resource materials, as well as the recording for this webinar so that you can also follow along, including those who were not able to join. So thank you, colleagues, and bye-bye from our end.
Thank you. Bye-bye.
Bye-bye.